Dirk-Jan van Ginkel and Mike Gibson coming to you live from ESC 2024. And we're talking about a common occurrence. Should we stop anticoagulation before TAVI? So, Dirk, talk to us about what you did and what you found.
Yes, so for most patients with severe aortic stenosis who are treated through transcatheter aortic valve implantation, TAVI will be used to TAVR in the US. So despite recent technical improvements, these patients remain at risk for thromboembolic events, but also for bleeding. And especially the subgroup of patients with oral anticoagulation, mainly due to atrial fibrillation. These patients are at higher risk for thromboembolic events, for example, ischemic stroke, but also for bleeding due to their underlying disease, but also due to their anticoagulation which they use. And general guidelines recommend to interrupt oral anticoagulation in such patients undergoing a high bleeding risk procedure. But specifically for TAVI, there has been some observational studies which suggested that when you continue oral anticoagulation throughout the periprocedural period, this was not associated with an increased risk of bleeding, but a lower risk of stroke was suggested. So therefore, we thought this is a promising strategy. And therefore, also, we designed this trial to study the safety and efficacy of this continued oral anticoagulation strategy.
And what did you find?
Yeah, so the trial was designed as a randomized non-inferiority trial, which was performed at 22 European sites. And we randomized patients either to a continuation strategy or an interruption strategy with a primary outcome of cardiovascular mortality, stroke, myocardial infarction, major vascular complications, and major bleeding. And what we found is that the risk of the primary outcome, it was 14.8% in the interruption group, whilst this was 16.5% in the continuation group. So the risk of the primary outcome, it was about 2% higher in the continuation group. And therefore, the upper boundary of the associated 90%, 5% confidence interval exceeded the pre-specified 4% non-inferiority margin. So therefore, the non-inferiority of this continued oral anticoagulation strategy could not be established.
And was the other strategy superior, or was it non-inferior and not superior?
So it was not non-inferior because the upper boundary of the 95 confidence interval was higher than the margin, but right. The 95% confidence interval also included 0. So right. It was not that one strategy was superior than the other, but we just could not establish the non-inferiority of this continuation strategy. And therefore, for clinicians, we interpret this as evidence supporting interruption of oral anticoagulation. Right. Because that's what the general guidelines advise, and there seems to be no reason to deviate from such guidelines.
Exactly. Well, again, this is why we do randomized trials. It adds an important piece to what we know. Thank you, Dirk, for joining us, and thank you all for joining us here live from ESC 2024. Thanks.
You're welcome.